Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Urologist. The last session we have discussed about an introduction to upper GI bleed, the etiology, definition, and what are the difference between upper GI bleed and lower GI bleed. Today I will be discussing the second session, assessment of severity of upper GI bleed. That is today's topic. We'll go by the ABCD approach. So there should be an immediate assessment, stabilization, determine the source of bleeding, stop active bleeding, treat underlying cause, and prevent recurrence. These are the basis on which we should manage a case. So assessing the severity, you go by the ABCD approach. So let us. The assessment of the hemodynamic status is the most important thing in the initial management. So how will you assess the hemodynamic status? Postural hypotension and tachycardia indicates 10 to 20% intravascular volume loss. The last session we have discussed about it. So any patient coming with upper GI bleed and the BP more than 100 millimeters of mercury, you make the patient sit up and then make the patient stand for 3 minutes and record the blood pressure. This should be a part of routine examination. The postural hypotension signifies a loss of blood volume, and you can have an idea regarding the severity. If the BP doesn't fall, no postural fall. Postural fall means systolic BP more than 20 millimeters and diastolic BP more than 10 millimeter fall. That is the. If there is no orthostatic hypotension, it's only minor thing, less than 10% of the plasma volume is lost. 10 to 20% loss if there is an orthostatic drop. That is, the 20 millimeter systolic or 10 millimeter diastolic fall is there, 10 to 20% intravascular volume is lost. And if the patient has got a shock or hypertension, that indicates 20 to 25% blood volume loss is there, and it is a severe case of upper GI bleed. So I repeat again, postural hypertension and tachycardia indicate 10 to 20% intravascular volume loss. So it should be mandatory in all patients, but should not be done when the patient has got a low BP or BP less than 100 millimeters. Then you go for the risk stratification tools. There are two major tools. One is the Glasgow-Blatchford Score, otherwise called GBS. It is for pre-endoscopy risk, and the Rockall Score for post-endoscopy prognosis. So these are the two scores you should remember: the GBS, Glasgow-Blatchford Score, and Rockall Score. It is not easy to remember it by heart. You can document it. And the must-know facts. Tachycardia is an early sign of hypovolemia, but the problem is patient with variceal bleeding, they may be on a beta blocker, and so the resting heart tachycardia may not be there. Second most important, the orthostatic hypotension, which we have already discussed. Look for capillary refill time. So how do you assess the capillary refill time? You press over the nail bed and release it, and the blanching should disappear within 2 seconds. If it is 2 or more seconds lasting, that indicates decreased perfusion. Hemoglobin is not useful because initial phase the hemoglobin can be normal, to take time for the dilution to occur. So this is the Glasgow-Blatchford score. It has got one, blood urea, second is hemoglobin, third is systolic BP, fourth is heart rate, then symptoms like melena, syncope, hepatic disease and cardiac failure, and you have to score it depending upon this. I don't go into the details of this. Next is the Rockall scoring system. It is, as already mentioned, is for the post endoscopy. Again, the variables are age, comorbid conditions, shock, source of bleeding, stigmata of recent bleeding. The charts are available. You can go through this and identify what is the score. Resuscitation and initial management. So in a patient coming with upper GI bleed, the most important thing is resuscitation and initial management. Start IV fluids, normal saline or lingeractate. Don't give dextrose. Dextrose is contraindicated. Oxygen supplementation if required. Transfusion if symptomatic or hematocrit less than 25% or hemoglobin less than 7 grams. Hemodynamic resuscitation precedes diagnostic evaluation in unstable patients. So this is something that you should remember. That is, hemodynamic resuscitation has got priority over diagnostic evaluation. History and general examination will give you a lot of clues. Age of the patient, the use of NSAIDs, that is the most important thing you should ask, plus antiplatelet drugs like aspirin, clopidogrel, of course alcohol. Look for signs of portal hypertension and stigmata of liver disease, and think about malignancy, loss of appetite, loss of weight, dyspeptic symptoms, etc. So by this we can, and again the Mallory-Weiss syndrome, there may be retching. Usually it occurs after recurrent vomiting, but as mentioned can occur during the first episode itself. So take a brief history. Then as mentioned, sometimes there may be confusion to differentiate upper GI bleed from lower GI bleed, about which we have discussed last time. Auscultation of the abdomen gives a clue, because in upper GI bleed usually it produces increased bowel movements, hyper movements of the even the bowel sounds may be heard more than 30 per minute. Diagnostic evaluation includes a complete blood count, LFT, RFT, that is blood urine nitrogen and creatinine, and PT-INR, platelet count. Always do blood grouping and cross matching, and platelet count. Then comes the major diagnostic evaluation. Upper endoscopy should be done within 24 hours. Endoscopy within 24 hours improves diagnostic yield and reduces rebleeding risk. So that is the importance of. So the gold standard, this is for diagnosis and management, upper GI endoscopy. Nasogastric lavage is controversial. In obscure bleeding, no cause is found, you go for a CT angiography. This is, and we had last time mentioned the major causes. I will just review the major causes. Peptic ulcer disease is the most common, followed by esophageal varices, Mallory-Weiss syndrome, gastritis, NSAID-induced erosions, duodenitis, portal gastropathy, malignancy. Rarely the vascular lesions. Peptic ulcer disease remains the most common cause of non-varicose upper GI bleeding. Remember this point. Up to 50 to 70% of the upper GI bleed is due to peptic ulcer disease. The second concept you should keep in mind is endoscopy should be done within 24 hours, which improves the outcome. Ideally within 4 hours, but at least within 24 hours. endoscopy should be done. The endoscopic has got diagnostic and management aspects. You can do the endoscopy can be utilized. Here it shows the endoscopy showing ulcers, showing the varices, portal gastropathy, etc. can be. This is the Mallory-Weiss tear. So the management then comes depending upon the etiology. Today we'll just briefly mention what are the major headings under which you manage. In peptic ulcer disease, you go by the IV proton pump inhibitors. And second is the endoscopic hemostasis. For varices, octreotide, banding, and in patients with cirrhosis and ascites, you may go for antibiotics to prevent spontaneous bacterial peritonitis. Mallory-Weiss tear is usually self-limiting. Endoscopic therapy if active bleeding is there. So this is the major or the general guideline regarding management. So last time mentioned about the risk stratification, go by the Glasgow-Blatchford Score, and post endoscopy go by the Rockall Score. Risk scores guide triage and identify candidates for early discharge. So the triaging should be done. Now we look at what are indications for ICU admission and surgery. Persistent bleeding despite endoscopy is an indication for surgical consultation. Somebody has got initial management, hemodynamically unstable, again go for a surgical consultation. When there is a large transfusion requirement, again surgical consultation. Surgical consultation is warranted when endoscopic and medical therapies fail. So when the medicines are not sufficient to manage the patient and the hemodynamic stability is not achieved, bleeding continues, go for a surgical opinion. Next step is the prevention of rebleeding. In peptic ulcer, you go for eradication of H. pylori, long-term PPI for NSAID-induced ulcers, avoid NSAIDs and antiplatelets if possible, and beta blockers for reducing the portal pressure. So this is the guideline for prevention of rebleeding. So here we'll go for a case. A 60-year-old female on NSAID presents with the melena. Hemoglobin is 7.2, BP 100/60. Definitely you should make the patient sit up and stand up and take a look for postural fall to assess. And resuscitation should follow before the diagnosis. IV access, 2 large bore cannulas, and start on fluids, crystalloids. Blood transfusion if hemoglobin is less than 7 grams per deciliter. If the patient has got CAD, the indication may change. Even you will look target for higher hemoglobin levels. Then go by the pharmacological management. You give PPA infusion, omeprazole or pantoprazole 80 mg bolus followed by 8 mg infusion per hour. If the patient has got a variceal bleeding is suspected, you go for octreotide, antibiotics like ceftriaxone if patient has cirrhosis. So basically the major etiologies are erosive gastritis, peptic ulcer disease, variceal bleeding, and Mallory-Weiss. So in variceal bleeding, you go for octreotide, think about giving antibiotics. For peptic ulcer and erosive gastritis, you go for the proton pump inhibitors. IV 80 mg of omeprazole or pantoprazole followed by 8 mg per hour. So this is the management. Endoscopic intervention should be, patient should undergo endoscopy within 24 hours depending upon etiology. Interventional radiology can be considered if the bleeding is intractable. So the leading points, NSAIDs are common culprits. start PPI infusion. High risk ulcers requires endoscopic management. So, quick recap. During the last few minutes, we have discussed about the definitions of upper GI bleed, the differentiation of upper GI bleed from lower GI bleed, the major causes, the initial assessment, diagnosis, and a guideline regarding management of specific etiologies. The references are from Harrison, Davidson, and the clinical diagnosis and management by Tinsley Harrison. In the next session, we will be discussing on emergency management of acute severe upper GI bleeding. So that session is mainly on highlighting the management aspects in a little more detailed way. Hope it was useful to you. Stay tuned.